In the next 37 minutes, we have to cram in 8 hours worth of training that you might expect within a typical buprenorphine training. The goal of this presentation really is just to give a snapshot of some issues about what buprenorphine is, how it can be effective for patients for opioid agonist therapy, and how to induce people on buprenorphine therapy. Before I begin, though, just to give a snapshot of the audience, how many people here know what buprenorphine is? That was the easy question. How many people are prescribing buprenorphine within the confines of your OAT, your treatment program? Excellent. So what we're going to plan to do with a series of 3 lectures, and we'll each get 10 minutes, and talk a little bit about both introduction to what buprenorphine is. We'll talk a little bit about induction and how to actually start someone on buprenorphine. And then we'll end up in terms of how to deal with comorbidity issues and co-occurring disorders with buprenorphine and managed care issues with buprenorphine. So, really quickly, as we mentioned earlier today, the Data 2000 Act allowed qualified physicians in order to prescribe for opioid-dependence treatment outside of traditional methadone clinics. In general, qualified physicians were defined by 7 measures, but the main 3 are those who have received addiction certification from an approved organization, have been a physician in a clinical trial of a qualifying medication, which was only buprenorphine. But the most important one is that you have to complete an 8-hour course from an approved organization. And those organizations are AOA, ASAM, AAAP. After you go through this training, you apply for a waiver and you receive a DEA issues you a new DEA number which has an X in front of it, which allows you to prove that you have qualified in order to prescribe buprenorphine for office-based treatment. And as of today, as I'll mention in 2 more slides, there's only been 1 medication with 2 formulations that have been approved for use, and that is the qualifying medication. The key thing about Data 2000, and I don't want to go into too much detail, but as we mentioned earlier today, Data 2000 was really intended in order to open access to treatment for people who weren't able to go to methadone clinics or didn't want to go to methadone clinics, and really allow this type of therapy to go into traditional healthcare settings. As we've talked about briefly this morning, methadone clinics generally have criteria in order to be admitted to those programs. You generally have to have physical dependence. You have to have 12 months of continuous use. Your dose generally is regulated on protocols. Generally, age over 18 is required in order to get to methadone clinics. Take-homes are limited and are regulated based on time. And services in methadone clinics, based on the state that you are at, generally can be regulated in terms of what services you must provide for every patient who goes to that methadone clinic. Data 2000 opened it up so that you can provide qualifying medications by qualifying providers to provide opiate-dependent treatment with different criteria. You have to have a diagnosis of opiate dependence as a diagnostic disorder, not necessarily physical dependence. This basically opens up the sporadic opiate dependence user who has not continuous use, but is causing quite a bit of harm, and AKA think of adolescents and young adults who are not that typical person who's shooting up heroin every day. Generally, the MDs, the physicians who are providing this medication, I'm going to switch. At the end of the day, can I tell you? Okay. So generally, the MD sets the dose, just like we would do for hypertensive medications. Maybe it's me. Hypertensive medications or depression medications, the age generally is over the age of 16. Take-homes are allowed. You can basically provide buprenorphine just like any other medication. And services generally are required to be available in order to prescribe buprenorphine in office-based settings. In terms of the medications that we're talking about, buprenorphine has several properties that allow it to be very useful as an opiate agonist treatment in office-based settings. It's a partial agonist that is less reinforcing than a full agonist would be. Generally has provided easier withdrawal and easier treatment of withdrawal for people. And there's a safety and overdose ceiling effect that provides quite a bit of safety factor for buprenorphine over other opiate agonists. It has high affinity to the opiate receptor, which is very advantageous, and I'll talk about that in the next slide, or next two slides. It has a long duration of action, such that you could perhaps provide buprenorphine over the course of 2 days rather than just every day. Some trials have actually been doing a 3 times a week dosing. And again, it has a strong safety profile, less respiratory depression than a full agonist would have, and less overdose potential. We've seen this slide many times. If you've gone through the 8-hour trainings, you've seen this over quite a bit. Full agonists such as methadone or heroin, morphine, oxycontin are full agonists, partial agonists are buprenorphine. It has not the full effect as a full agonist, but in many respects has a stability efficacy equivalence of methadone. Here's a high affinity issue. This is why it's really attractive for many providers. Buprenorphine sticks on that mu opiate receptor extremely well and very tightly. So if you look on the left side of the slide, you have buprenorphine that's sticking on that mu opiate receptor. If someone injects heroin, heroin doesn't get on that receptor, therefore it acts like a blocker. And we'll talk about this with induction with Dr. McNicholas in the next talk, that if you're on a pure opiate and you like methadone or heroin and you provide buprenorphine, that'll kick that pure agonist off because of that high affinity and has implications of how you dose and induce people on buprenorphine. Here are the formulations for buprenorphine. There are many of them. If you talk to your anesthesiology colleagues, they know buprenorphine extremely well. It's well known in the literature, in the anesthesiology literature, and the perioperative medicine literature. Buprenorphine is IV formulation is called Buprenex. It is not approved for opiate dependence treatment. Only the sublingual formulations of buprenorphine are allowed, or FDA approved. Sublingual buprenorphine comes in 2 forms, both a pure mono product called Subutex, sublingual, comes in a 2 and 8 milligram tablet. It only really has one indication. If you have taken your training several years ago, we were suggesting that people take a pure mono product when you induce. That is no longer true. The only indication for a pure mono product, Subutex, is pregnancy. Don't need to induce with the mono product anymore. Just use a combination product, which is called Suboxone. Again, it comes in a 2 to 8 milligram tablet. Why do we have naloxone in the tablet? Rhetorical question. That'll be the next slide. There are some studies going on in Europe and the peer-reviewed literature about buprenorphine transdermal and even a buprenorphine depot injection, very similar to what we're seeing with naltrexone depot injections. And I'm sure you're going to be hearing about these formulations in the next several years. Let's talk about what the monoproduct and why we're using the combination product, Suboxone, for the treatment of opiate dependence. Why do we add naloxone to the formulation? This slide talks about the pure mono product, okay? Buprenorphine or Subutex. You could take it 3 routes. You could do pararectal, but I don't think many people would do that. You could take it orally. If you take it orally, buprenorphine is generally not absorbed very well, so that you don't have naloxone on, and that's not absorbed. And the outcome is pretty bland, no action to the patient, and the provider doesn't get an effect either. If you take it sublingually on the right side, we'll do this middle slide first. If you happen to crush up that tablet and inject it, which is called diversion, and our patients like to inject things, buprenorphine is absorbed. It basically causes the same problem that you have with heroin, morphine, and all that stuff, in that you're injecting, causing medical harm, hepatitis, HIV, and all the associated products. So the patient is very happy, although I will say not too happy because it's just a partial agonist. You can get heroin on the streets for $5. Buprenorphine in Pennsylvania, at least in Pittsburgh, I'm not sure in Philadelphia, is still being sold for about $10 on the street. It's cheaper to get heroin, much more bang for your buck. But anyway, you can inject it, you get a small partial agonist effect, you'll get an effect. If you take it sublingually, it's correct, technically, because it will go underneath your tongue, the buprenorphine will be absorbed, and the patient's happy and you're happy. We don't want that middle scenario, okay? So what we put, not we, but the pharmaceutical company put in, naloxone. Naloxone is an opiate antagonist. If you take it incorrectly by the mouth and swallow the pill, you have not really much absorption of buprenorphine, not much absorption of naloxone. Again, a bland effect. If you happen to take it IV, okay, which is again diversion, you have buprenorphine which is absorbed, but whoa, the naloxone is also absorbed. Therefore, basically canceling out that first rush of buprenorphine that you're going to get IV, basically causing potentially withdrawal from that patient. If you take it sublingually, which is correct, you can basically get buprenorphine absorbed. The naloxone is not well absorbed in the sublingual mucosa. Therefore, you get the same kind of effect as you could with the mono product. So if anybody's out there seeing a lot of pure mono product of Subutex out on the street and or from physician offices, you should let them know that they should be using a combination product or Suboxone with buprenorphine. Make sense? Usually that takes about 30 minutes to go through, but we did it pretty quick. So in terms of my primary practice, when I started using buprenorphine, this is the most common quote I heard. Doc, I feel normal. In many respects, just like Dr. Salsa said this morning, we've legitimized this as a medical illness that can be treated in regular settings by regular providers in regular treatment modalities. It encourages the continuity of relationships with primary care providers and outpatient providers. It encourages relation building with clinicians, especially with these patients with comorbid medical disorders. And it legitimizes opiate dependence as a medical disorder that needs to be treated. It has opened up avenues for people to get access to treatment that would not otherwise be available. And before I begin, or before I go further, I'll just mention, even though I'm a very good buprenorphine advocate, I'm just as strong advocate for methadone. People have choices, and we can provide options for people. It's okay to provide buprenorphine, and by the way, I advocate for many of my patients to go to methadone clinics because they need to have that structure that methadone clinics provide. Just a couple slides about the efficacy and efficiency of buprenorphine. Buprenorphine does provide treatment retention. This is a study from Dr. Johnson, which basically showed that buprenorphine was generally equivalent to 70, 80 milligrams dose of methadone in terms of treatment retention. The next slide talks about clean urines. I hate that word as well. A negative urine for opiates is what I usually say. Buprenorphine did just as well as high-dose methadone in terms of preventing people from using illicit opiates. Very effective. This is in a research study. Another research study had buprenorphine provided as either a detox medication or buprenorphine provided as a maintenance medication. This is a study from CACA, which basically had everybody here had all the CBT that they could ever want. They had all the wraparound services that they could ever get in terms of treatment research study. The arm that had detox, no one retained it to the study after 1 to 2 months or 50 days. Those were in maintenance therapy, maintained through the course of a 1 year, and did fairly well in terms of retention into treatment. And oh, by the way, those people that were randomized to detoxification, there were 4 deaths in that arm. Very significant, very powerful statement that detox doesn't work, that maintenance therapy might be more effective. Interesting thing, another study which showed from Fidal in 2003 is that if you look at different types of illicit drugs that people are also taking polysubstance use, if you're on buprenorphine over the course of a year, generally people, when they're engaged into treatment, will start to improve their illicit use of other substances particularly in this study, just look at the line for cocaine. Cocaine-free urines basically got better over the course of a year. Even though you're treating one disorder, you're influencing the other disorder. First disorder, opiate dependence. Second, cocaine dependence. This is the last study I want to mention in terms of retention. This is recently out of Rhode Island Medical Center with Stein, who basically looked at retention within a normal primary care practice, which as people started on buprenorphine, the y-axis is retention rate, the x-axis is the number of days, and the skinny of this study basically is that after 24 weeks of treatment using buprenorphine, 59% of the patients remained into treatment in normal practice settings. These are general practice settings just like you and I would have in both rural and academic medical centers. Pretty powerful statement to get people into care and get better. One of the last things I want to mention is that, as you know, there are many surveillance studies in terms of buprenorphine, and also surveillance studies in regards to what kind of drugs are out there on the street. This is out of New England Journal of Medicine in 2005, which is the latest data that I had, which looked at the number of cases on the y-axis of abuse of drug per an abuse or an addiction medicine physician. And in general, from addiction medicine physicians out in the country, buprenorphine is not being diverted as much as oxycodone or even methadone as it's slowly creeping up. The major thing that people are seeing on the street in terms of diversion of buprenorphine is not to use it to get high, is to give to their friends so that they can help go through withdrawal. And oh, by the way, I don't like to hear that, but it does encourage people to come to me into treatment saying, I got it off the street, it really works, can you provide it for me? And that's a very powerful statement. That's a pretty good diversion in general. The last slide I have in the 10 minutes that I have to present this 8-hour course to you is some useful websites. There is quite a bit of information about buprenorphine. And by the way, in terms of the 8-hour course, there's one in Harrisburg in 2 weeks, or next month, 1 month from now. I'm not sure the exact date. It's usually on a Saturday. I think it's the 6th or something like that.
It's either the first or second Saturday in June.
First Saturday, I think, of June. And you can email me, and I'll let you know what the exact time is. By the way, you can go to these websites and find out many of these training courses that are available. There are also web-based courses available now, too. I will make a plug for the PCSS, which is the bottom bullet, which is a mentor network, which many of us have talked today are involved with. It really helps people get started on buprenorphine and learn about it, and you have someone to call or email for questions. So with that, I'm glad I get through it in 15 minutes rather than 10. I think we're talking a little bit about induction.
Is something that you guys are going to understand. So you're going to get not the 2-hour version, but the 10-minute version. When we talk about induction for buprenorphine, we need to look at a lot of the same issues that we need to look at for a patient coming into the OTP. And a lot of that is patient assessment and that sort of thing. Now, Adam actually pointed out the major differences is that the person doesn't have to be dependent for at least a year to get buprenorphine by prescription. If they're being admitted to the OTP for buprenorphine, they do. So, but one of the things that I always tell people is you need to think about, are all the necessary assessments completed before you give them a pill? And I do the same thing with my methadone patients. The H&P, did it get done? Do they need an EKG? If they do, has it been done? Labs, appropriate for the patient? Psychosocial assessment? Before, during, or after induction, but that's got to be done. And consent for treatment. A lot of people forget this with buprenorphine. We know we have to do a consent for treatment for methadone, but a lot of people out in the general practice area, you need to do a separate consent? Yeah, you're putting them on a drug that on which they will be physiologically dependent. And is the patient education for induction complete? One of the things that is very different about this medication is it is a sublingual tablet. It is not an instant dissolve. They have to keep their mouth shut and not swallow while the pills are dissolving. It doesn't taste good. And during one of my studies, actually one that Adam had some data up on there, I did a quick and dirty experiment on my own subjects, and it was like how long after I give them the pill the first day and tell them to keep their mouth shut. They asked me a question, and the answer was 12 seconds. And the medication takes 3 to 5 minutes to dissolve. Hello. So you really do need to do some education with your patients if you're going to be starting to use buprenorphine. Determine when, how, and where you're going to start it. And believe you me, when you're talking about changing a patient from methadone to buprenorphine, this is an issue. I've done it. It's not a simple thing to just go, oh, here's points 1, 2, and 3, you're done. So you need to think about how, when, and where you're going to start the meds. Tell the person not to use opiates for an appropriate amount of time, and we're going to talk about what's appropriate. I like them to not be driving day one. In Philly, they can take public transportation. They can have somebody drive them in or whatever, but I would rather that they not drive home that day. For your patient who is not physiologically dependent on opioids, it's a piece of cake. You're not going to have withdrawal, so all you do is start on 2 milligrams, slowly increase it, because all you're dealing with is the craving. The only thing that people say that they might see with this patient is a little bit of sedation with buprenorphine. Never having seen it, I don't know. But this patient not physically dependent is rare bird, let's face it. For your person who is coming in using short-acting opiates, i.e. oxycodone, heroin, etc., they need to be abstinent from opiates for, we tell them 12 to 24 hours. I hope that they give me 10. They do have to be in withdrawal at the time of the first buprenorphine dose. And I know that some of the people will, well, they look like they're in withdrawal to me. One of the things that Dr. Taylor was talking about is you should really use a scale to determine if the patient is in withdrawal. With this drug, you need to use a scale to determine if the patient is in withdrawal. And if they're not in withdrawal, they don't get medicated. I like to use the clinical opiate withdrawal scale, the CAL scale. I like a score of about 13. If they're not at 12 to 13, they don't get medicated. They can either wait and see if they go into enough withdrawal later in the day, or they can go home and try again tomorrow. But if I medicate them and they are not in withdrawal, they will be in withdrawal, because you will precipitate abstinence with this medication if they are not in sufficient withdrawal. Unlike methadone. Methadone, you're not going to be precipitating abstinence. You may overdose the patient, but you're not going to be precipitating abstinence. With buprenorphine, you will not overdose them, but you can make them sick as a dog. So in that respect, they are absolutely converse. What we do recommend is once the patient gets to a sufficient amount of withdrawal, you give them 4 milligrams of sublingual buprenorphine naloxone. I agree with that, and there's absolutely no reason to use anything other than the combination unless the patient is pregnant. Monitor them. I usually go for an hour, not 2. Where am I? There I am. I really did it good. Okay, and then I usually give them another dose of 4. So most patients in my practice get about 8 milligrams on day 1. And they're comfortable. They sleep that night, they eat dinner that night, they do well. And some people say that they need to go over 8. I very, very rarely need to go over 8 milligrams on day 1. Some people like algorithms. This is where the art of science of medicine comes in, as well as the science of medicine, and that is how do you switch a patient from methadone to buprenorphine. I wrote the guidelines. What I wrote is get them down to 30 or below, wait 24 hours. It don't work. Get them down below 30. I actually like them on about 20. I like them to wait about 48 hours. And then I start looking at them to see whether or not they've got some withdrawal. Most patients on 30 milligrams will be precipitated at 24 hours. That's my clinical experience. I have a patient right now who wants to switch from methadone to buprenorphine. He's on 20. We were going to actually try it, but he couldn't make the entire 48 hours. He took his last dose on a Saturday morning. He was to see me on Monday morning. He said 11 o'clock Sunday night, he was just miserable. And so he took a dose. He called me first thing Monday. He goes, I don't think there's any point in me coming in because I had to take a dose last night. We need to rethink this. He's a very responsible patient. We are rethinking it, and we will come up with a better way of managing his intro into buprenorphine. But for most patients, 15, 20 milligrams a day, wait about 48 hours. They are going to be uncomfortable. And then you start low. And you start with about 2 milligrams, not 4, unless they are really actively in withdrawal. And then see whether or not you need to go up. I have literally had patients on 15 to 20 milligrams of methadone, and at 48 hours, I give them 2 to 4 milligrams of buprenorphine, and they're perfectly comfortable, and that's where they stay. And so it's as much an art as a science on switching these patients over. By the way, the patients who have switched over have done beautifully. Again, on the second day, we recommend that the patient be reevaluated. Do they need an increase in their dose? How was the night? Did you get enough in the day before? And then you adjust it. One of the things I tell my patients, and this everybody will tell you that I am an absolute dictator about, is they don't change their dose without talking to me. If they do, they don't get another dose. They can go to methadone. But we adjust the medication together on days 2 and 3. And usually by day 3, you're on a stable dose. We recommend that the dose go up by 2 to 4 milligrams a day. You can go up by 8, by the way. Initial target dose of 12 to 16. I have one patient over 16 milligrams. At 16 milligrams of buprenorphine, you are occupying somewhere between 92 and 95% of all mu opiate receptors in the brain. At 32 milligrams a day of buprenorphine, you are occupying 93 to 96% of all opiate receptors in the brain. However, if your patient wants to get creative, they've got 2 tablets of buprenorphine that they don't need. And that's where what Adam was talking about, showing up on the street. I don't see any reason to go over 16 milligrams in normal cases. There may be a couple of patients somewhere who need it, but most of mine don't. Okay. Patients get anxious, particularly patients who have been on methadone. If you're doing this in the office, they get a little anxious. I'm not going to be seen on day 2. I'm not going to be seen every day, and stuff like this. I usually find phone calls are great. I tell them not to use. Somebody made the slide that said, discourage opioid use. I do more than that. I would say I strongly discourage opiate use. I do more than advise them not to change their dose without consultation. And I have never needed an ancillary medication, but I know some people who will use a little bit of Cerax or something in the initial doses. Stabilize them on a daily dose. The guidelines say 8 to 32. The label says up to 24. As I said, the average dose in the United States is between 12 and 16 now. We actually hit that one right on the head when we said that to aim for a target. The average dose is about 12 to 16 milligrams a day. If your patient is on more than 2 tablets, they have to take them sequentially. Now that doesn't mean in divided doses. That means that they take 2 8-milligram tablets, wait 5 minutes, and take whatever else they have to take. If you try and put 3 8-milligram tablets under your tongue, you've got chipmunk cheeks for 20 minutes, and Lord knows what your absorption is. So 2 tablets is maximum at any given time. I leave this slide in for the very simple reason that not everything is pharmacologic. When your patient is on an appropriate dose of buprenorphine, i.e. about 16 milligrams or so, and they continue to have urines positive for opiates, then you need to figure out what else is going on. There are a couple people in this room who heard this story probably ad nauseum, but I actually had a young woman, little tiny blonde girl, I actually had her up to 24 milligrams. She still came back with about every 3rd urine positive for opiates. And we did all of the normal stuff, and I finally threw all of my psychiatry training out the window, and I stared her straight in the eye. I said, when you use heroin, do you get high? She said, huh? I said, when you use, do you get high? She said, oh, no, I haven't gotten high in a long time. I said, then why are your urines positive? I like to stick needles in myself. Let's try dealing with her borderline tendencies. We might get a lot further, and that's not going to respond to pharmacology. So make sure that you remember that some of it's psychosocial, and these patients, whether they're in your office or in your clinic, have the same problems, and you need to address those in a psychosocial and supportive fashion. She did quite well after we started doing that. Make sure your patient is stabilized. If you're going to be using buprenorphine in The opiate clinic, once you establish a daily dose, your patient can come in less than daily. They can come in thrice weekly on a Monday, Wednesday, Friday schedule. For those of you who ever used LAM, this was one of the benefits of it, was that patients didn't have to come in every day. For patients who have buprenorphine to take at home by prescription or something, I do not recommend less than daily dosing. They can't remember what Monday is versus Tuesday. But for patients who are coming into the clinic, they can come in on Monday, Wednesday, Friday. If they stabilize on 16 and you're going to a thrice weekly dose, you would double for 48 hours and triple for a 72. That way you don't have to worry about take-homes or anything else. It's going to take them a while to take, 6 tablets in the clinic, but you don't have any take-homes that you have to worry about. So you can do it with less than daily dosing in the OTP if you're going to be using buprenorphine there. What about tapering? Hopefully your patient is stable. Unfortunately, some of our patients decide, just as they do with Methadone, that, okay, it's been 6 months, I guess I'm well. And they're ambivalent, they may want to discontinue. If they are in fact stable, my golden rule, and I don't care whether it's Methadone or buprenorphine, is never to destabilize a stabilized patient. I don't care how long it takes me to taper them. I had one notable patient in a Methadone clinic, took me 3 years. But I do it as slowly as I need to, and I have gotten to the point where both with Methadone and buprenorphine, I build in plateaus. If my patient on buprenorphine is starting from 16, we go down to 8 milligrams, dropping 2 milligrams a month, and we stop at 8. And how do you feel? What I have found, and it's the same with buprenorphine as it is with Methadone, is the patient's addiction starts playing head games with them. Is this what I really should be doing? Am I setting myself up for failure? So, okay, so we stay on the plateau and you stabilize, and when you're ready to continue the taper, we do it. Make sure that they increase their psychosocial support. This is not a good time to get out of touch with their sponsor. And if all else fails, you reinduct. Not a hard thing. And 10 minutes and you've got 8. We'll have questions as soon as you finish.
I will try to do this in 5 minutes and talk really quickly and just make a few key points. Fortunately, a lot of the themes I was going to talk about, actually, Dr. McNicholas really covered earlier when she was talking about psychosocial treatments that accompany Methadone. The issues are really very similar with buprenorphine. Just a couple words. I'm glad buprenorphine was really glad it was on the agenda for today. As a managed care organization, buprenorphine is a really positive option, we think, for our members. One is, as I talked about this morning, lots of people use mental health services, frequently have concurrent substance abuse problems, and undoubtedly the most common one is opiate addiction. So anything that offers more treatment alternatives for people with opiate addictions is good for the members. The second is, as you saw on the map this morning, there's still lots of places in the state that don't have opiate treatment programs, and buprenorphine is available, at least in theory, in PCP offices as well. The places that don't have methadone treatment programs don't have many PCP offices that prescribe it either, but it at least is another potential option. And the third is we're really committed to the concept that you heard talked about earlier about members' recovery, and really trying to work with members so that they're in an autonomous position. Going to any medical setting daily, really, it's hard to see that as supporting member autonomy, at least in some ways. So to have another treatment that really decreases members' needs to go to the medical clinic every day and to offer them some increased control in their life is, you really see as positive. I was talking with Dr. McNicholas on the side for a minute, and she asked about payment for buprenorphine for treatment in methadone settings. And the MA program in Pennsylvania hasn't, I think, really fully thought that through yet. The initial model for buprenorphine, the idea was that it would primarily be done in PCP offices. And so that the model under which it's used in Pennsylvania the payment model through Medicaid is that it's covered as a part of the person's pharmacy benefit through their physical health plan, which they're going to their PCP office and they're going to pick up a prescription, once a week or a couple of times a month. Makes sense. Within a methadone program, where at least the treatment model is more intensive treatment and that the patient comes there more, and typically, certainly for methadone, patients get their medications through the clinic. Obviously, it's a different model that doesn't quite fit. We'd certainly be happy in any of the counties we work in to sit down with treatment programs and try to think it through. I know just as an example on the mental health side, there actually been, and this is throughout the country, there are mental health centers who actually have pharmacies in their mental health center. So I think there are models even within the current payment option. Buprenorphine is on the formularies of all the physical health plans and on the fee-for-service side. Some of the plans do have pre-authorization or reauthorization requirements. They're really ones that are consistent with the treatment principles we've talked about today, really checking has the patient, are they having a urine screen with some frequency, are they in concurrent behavioral treatment in addition to getting the medication, which would clearly be the case if they're in an opiate treatment program. So I don't think there are likely to be ones that would be barriers. Certainly, care coordination and collaboration are critical. And I think the intensity of what happens when the members are in the program probably is worth some thought as methadone programs add buprenorphine treatment, because the members will be coming there on average less often. So the frequency of contact is likely to be less. So I do think it probably prompts some ideas about rethinking what the intervention's like. A key part is really, I think, also screening for the comorbid disorders. We heard some about the concurrent psychiatric disorders that occur in folks with opiate addiction. I'll say another couple words about those. And the last is to really support members' recovery. Certainly the tip on buprenorphine treatment really says it's required to have concurrent counseling. Pharmacotherapy alone is clearly rarely adequate. And at least when buprenorphine came out, and we haven't talked very much about this today, about kind of selection for methadone versus buprenorphine. But at least the initial idea was that patients who are initially selected for buprenorphine who haven't had as long or intensive a history of addiction might be at higher, able to obtain higher levels of eventually tapering off the medication. So as we just heard, clearly having folks taper off and move to abstinence requires more intensive concurrent treatment. In treatment of comorbid disorders, certainly the screening's important. The most frequent concurrent disorders, one, certainly other substance abuse disorders. The second is depressive disorders. The third is PTSD. The fourth is, not surprisingly, substance-induced mental health disorders. And the last is personality disorders. I'm going to skip one slide here. Certainly this data is really from looking at patients not who have concurrent behavioral health and substance abuse disorders, but people who have concurrent medical and behavioral disorders of any type. And clearly in those studies, the best coordination of treatment is when both types of treatment are provided in the same setting by the same provider. The second is have treatment in the same setting by different providers. The third option is well-coordinated treatment. And certainly the managed care organizations, as well as the county treatment systems in many of the counties, can really help with that coordination. And the last thing I wanted to mention again was really supportive members' recovery. I'm not aware that there is really strong literature around this yet in the chemical dependency field. There is really strong literature in the mental health field. And I read, actually sponsored a conference a couple weeks ago focused on the concept of recovery in chemical dependency. But on the behavioral health side, just as an example, there is literature that says that for folks with chronic mental illnesses, actually having employment is probably as strong, at least a factor, in terms of their staying out of the hospital and staying functional as being adherent to their medications. So there's clearly a lot of synergy between those things. But undoubtedly, there's intuitively, at least it makes sense, that the same themes are going to be found to be true on the chemical dependency side as well. So really focusing, I think, with members on their work, family, spiritual, other areas that we talked about clearly is key. So it's 5 o'clock. I'm going to stop talking. I guess we're available for a couple minutes for questions.
Yeah, I'd like to open this up for 2 questions. Hopefully people don't leave before the closing ceremony that we have. Yeah, so we have a couple. I want to take 2 questions regarding buprenorphine in the last session. And again, I think this is not a buprenorphine workshop here. So if you have more questions, go to the resources we say. But go ahead.
My question is for those of us that in our clinics where we're dispensing methadone and those consumers are coming in either for partial hospitalization or intensive outpatient or outpatient groups. And now we're going to have consumers coming in for Suboxone as well. Any opinions about, from a treatment perspective, pros or cons, if any, about integrating those 2 populations into the same treatment group?
Actually, the only con that I would have for integrating them into the treatment group, and it's easily managed, but you have to think about it ahead of time, is educating your patients. Because as soon as people start talking about buprenorphine, the first thing that comes out of their mouth is, oh, that means I can come in once a month. And so you need to educate your patients that, first of all, not everybody on methadone should or can change over to buprenorphine. If they're on a high dose of methadone, it's going to take them forever and a year to get down to an appropriate dose for a switchover. Secondly, patients with chronic pain are probably not good candidates for buprenorphine. Thirdly, patients who require the structure of a methadone program may or may not be good candidates for buprenorphine. So what I would say is you need to make sure that you have an educational session, that there are going to be some patients who are going to be on a medication other than methadone, and it is buprenorphine, and we are not advocating that everybody move to it, and I can tell you that some of you are not eligible. I actually had to do that in my methadone clinic because it was like, oh, well, we're all going to switch to bup, and I went in and I talked about, oh, well, maybe it's not right for me. And I didn't have to tell them that. I gave them the information, and they realized that it wasn't going to be right for them. And so I think that that's really the only con. I don't see any, I mean, the pros are great. Because for one thing, a lot of the guys on buprenorphine, when you have a patient who's appropriately managed on buprenorphine and they're not using anything else, which is, in my experience, the vast majority of them, they're not nodding out, they're not looking tired, they're not looking silly in groups or anything like that. And it's like, oh my God, these people are actually, functioning, and I should be able to do that too. And that can be a real pro. And because, let's face it, some of our patients on methadone don't make it go through groups the entire way, staying awake. And your bup patients will. And that can be a reinforcer for other patients to look to where they actually are in their recovery and using the medications appropriately.